Hush, kids. Sorry. All right. So I've met most of you, I think. I just met you yesterday. Haven't worked with you yet, but we met in the past. Oh, of course, Dave. Of course. Yeah. So for those of you that I forgot, my name is Jake Lloyd. I was a former resident here and now a fellow in acute pain and regional anesthesia, and I'm also a senior instructor. I'm going to talk today about peripheral nerve block anatomy. It's going to be kind of a PBLD approach, so we're just going to go through some cases near and dear to my heart, and then I want to kind of cruise through that. I'm just going to leave it open-ended, so please, just if you know the answer, just blurt it out. If you don't, I'm going to start asking people very uncomfortably. So let's get through it, and then we're going to play with the ultrasound. Okay. So first case: 88-year-old woman with dementia, osteoarthritis, presented to the ED late at night with right hip pain after a fall. She received 4 milligrams morphine IV by EMS and route to the ED. She's now ANO times 1, mumbling incoherently and in obvious pain laying in her bed. X-ray of her right hip reveals a femoral neck fracture. The patient is scheduled to have her fracture surgically fixed, but that surgery is scheduled in the following morning. So, just off the bat, which nerve blocks, if any, are indicated in this patient? Looking at people who've done APS.
So you can do a femoral.
You can do a femoral, correct? And you can do a fascia iliaca. Those would be the first two that come to mind, and the two that we can most have. For the purpose of the basic exam, I think femoral is more important to focus on, and we can talk a little bit more about that. But suprainguinal fascia iliaca will also hit the femoral nerve, but is something that Jillian Bitter is implementing for the APS service for hip fractures as well. So I kind of alluded to it with this patient's history, but why is a nerve block particularly beneficial for this patient?
She's older and ANO times 1.
Mm-hmm. Probably from the morphine, right? So typically these patients do a lot better with an early nerve block intervention to minimize their opioids. And that's why there's a geriatric hip fracture protocol here at the university to respond as soon as possible to do a nerve block. All right, so same patient. You and your attending decide to perform a femoral nerve block for hip analgesia. You've never done a femoral nerve block before and silently begin to panic. Where will you initially place your transducer?
Inguinal crease.
Sure, inguinal crease over the pulse. So yes, you're going to go to the ipsilateral side, obviously. And you some patients, their inguinal crease might be an inguinal canyon, so there might be a panis. There might be a panis retraction necessary, but yes, you try to get into the inguinal crease by the pulse. We'll get into why that's important, but yeah, that's where you place it. Good. So after struggling immensely to find the correct view, you locate what appears to be 2 arteries. So at this point, what maneuver would need to be performed with the transducer in order to optimize the femoral nerve block field?
Scan.
Proximal cephalad. Yep. So what you're seeing with the 2 arteries is the superficial femoral is already branching off. So you're trying to now scan more proximal, more cephalad in order to get the single common femoral artery. And what is the order of the femoral artery, vein, and nerve from lateral to medial? Navel. What does that mean?
Okay.
Correct. Is that my email? I feel like I need to. Whatever. We'll just deal with this.
Just don't talk to them.
Yeah. All right. So you finally identify the proper view and start to place your needle in the skin. Roughly 1.5 centimeters deep, you feel the first pop with your needle. What is the structure that you just popped through? First pop, other than the skin. Fascia lata. Correct. What other structure needs to be popped through in order to effectively block it and get to the femoral nerve? Fascia iliaca. So 2 pops. Good. So after injecting 20 mLs of 0.5% bupivacaine along the posterior lateral aspect of the femoral nerve, You're feeling pretty good about yourself and begin to remove your needle, only to be reminded by your attending that there's another nerve that should be blocked for this patient because she has hip analgesia. Which nerve is this?
Lateral cutaneous.
Lateral femoral cutaneous. So for those of you that haven't done this block or haven't been on APS before, that is usually able to be done in the same needle pass. You just kind of pull back your insertion point being at its lateral to medial. You're probably passing right by the lateral femoral cutaneous on your way in. It lies just along that fascia iliaca plane, which is why the suprainguinal fascia iliaca also blocks this nerve. So you pull back to that fascia iliaca plane and just drop a little 5 mLs right there. It's like a little plain block, as you might not see this tiny little nerve, and that will cover the lateral femoral cutaneous. So it's very helpful for hip surgery because it covers a lot of the superficial tissue that they're cutting through for their surgery. So femoral and lateral femoral cutaneous is good for hip analgesia. This is kind of silly, but when you return the following morning to bring the patient to surgery, you see that she's resting comfortably, chatting with her family, and way less delirious, which obviously points to why we do regional on these folks. The patient's overly optimistic son asks if the patient will be able to walk after surgery while the block is still in effect. How will you counsel that patient?
Negative goes
Yeah, because
motor block.
yeah, and she has a broken hand. But yes, the motor block is what I was saying. You are going to knock out her slots. So that is an important thing to counsel for these patients, and why we don't do femoral nerve blocks for our knee surgery, because we want to make them working right away. All right, case number 2. 62-year-old man with obesity, diabetes, OSA, severe pulmonary hypertension, and coronary artery disease who presents for a second-stage closure of his BKA. Notably, the patient suffered an NSTEMI 3 days prior after undergoing a general for the first stage of his BKA. This is a true story. As this is your first day as an attending, you have a long conversation with the patient regarding the risks of repeating the general anesthetic, i.e. death. You discuss and opt for a surgical block with essentially no sedation. Which nerve blocks would need to be performed for surgical anesthesia for a patient getting a BKA, that's a below-knee amputation closure?
Popliteal and saphenous.
Correct. Popliteal and saphenous. You could also do popliteal and femoral, but because you're covering the same idea, same thing. But that is the correct, and that's, as you'll see. What we got into.
Popliteal and what?
Saphenous. So AC. So pop AC. This is a little verbose, but after teaching the reluctant pre-op nurse on Panis retraction 101, this guy was morbidly obese, you're able to visualize the femoral crease and notice a longitudinal scar along the track of the femoral artery. Slightly beginning to panic. The patient confirms that he's had a complete revascularization of his femoral artery. And upon placing the transducer in the femoral crease, all you can see is a mishmash of scar tissue and no identifiable anatomy. Fortunately, you remember that since this is a BKA, you can safely block, not clock, the nerve more distally in the adductor canal. How do you reposition the patient in order to optimize your view for the adductor canal block, and where do you place the transducer?
Frog leg.
Frog leg. What is frog leg in medical terms? External rotation and slightly flexibility. Yep. Also known as frog leg. And then where do you place your transducer?
In like transverse.
Yeah, transverse, mid-thigh, slightly medial, but yeah, you basically, proper way to do it for people just beginning is find the femoral and then slide medially until you see some more structure that you identify. And you're starting about mid-thigh is where you're going to see the sartorius passing over. Oh, I might have given you an answer. But we'll get to that. You obtain the best view possible and begin the block. Your patient winces as your needle passes through the muscle that makes up the roof of the adductor canal. What muscle is that?
Sartorius.
I'll give you an easy one. You pop through the fascia of the aforementioned muscle and begin to inject local. The patient again flinches and complains of a shooting pain down his leg. What distribution or path would the patient likely describe for this paresthesia?
It's like medial.
Yeah, so starting at the medial knee, down the medial calf, medial malleolus, That's kind of the saphenous nerve distribution. So good job. It does anterior knee, and that's why we do them for knee surgeries, TKAs, but you'll mostly feel it immediately. After completing a successful AC block, you move on to positioning the patient's thumb in a leg elevator device to prepare for your popliteal nerve block. Where do you place your transducer to begin the popliteal nerve block? Correct. Now you can do this laterally. We just tend to do it more with the posterior approach, but some people might want to do that maybe at other hospitals that can't afford a knee elevator type of device. So you might see it at the VA or Denver Health. Laterally is just instead of putting your leg up like this, they'll just lay the patient sideways, put your transducer still in the same place. Okay. I don't know if you guys have done nerve blocks in other hospitals, but they do things slightly different.
They do it at the VA, lateral.
Yeah. So it doesn't mean they're doing it wrong. They're doing the same block. Yeah. So yeah, it's preference. So you easily identify two hyperechoic structures sandwiched between several nerves. Keep in mind, you still don't know whether or not you're going to successfully be able to block this guy and save his life, i.e. avoid general anesthesia. So you breathe a loud sigh of relief when you actually identify these two nervous structures in his leg. And from this point, you're seeing two separate. What maneuver needs to be done with the transducer in order to optimize your popliteal nerve block? Yes. So you're going to move more proximal, more cephalad, bring those nerves together. As you begin your lateral approach popliteal nerve block without sedation, the patient jumps as you traverse through the muscle with your needle. Which muscle is the patient feeling this tenderness? Let me actually just... Hey, this is Jake. Hey, can you run it by Josh? I'm giving a lecture now. Josh due in. He should be around. I told him all about the patient. And yeah, is she doing okay though? Okay. Yeah. Not off the top of my head. Yeah, somebody should though. He's been there all day. I'm sorry. Thanks. Bye. No. All right, this is a tough one, guys. This is the first tough one, but if you look at there you go. So, yeah. Oh yeah, the exercise physiology guy. You will get pinched by certain attendings on what muscles you're seeing in these nerve blocks. So something to keep in mind. It's not just you're not just looking at nerves and vessels. You got to also keep in mind of muscles around as well. And that is a particularly tender one, honestly, when you're doing this block. You try to stay away from the tendon and go through the muscle belly. It's slightly more comfortable. So during your block, you lose sight of the needle, but foolishly just continue to advance your needle. You feel a pop and feel like you've entered the Volka's fascia, which is surrounding the sciatic. You ask your block assistant to aspirate before injecting. Lucky you ask, because pulsatile red blood flow is aspirated. Relative to the transducer, what direction do you want to redirect your needle in order to properly block? Keep in mind, we're leg elevator behind me, so relative to the transducer, artery, nerve. Or superficial. So closer to your transducer, which ironically, when you're doing the block, is down, because you're looking at a flip screen. So something to keep in mind. But good. So your vessels are going to be deep to your nerve, and that's something you will identify also in the popliteal fossa. You want to look at the vessels and see the relationship with the nerve. You regain your composure and find your needle with the ultrasound. But you've migrated caudally to a point where the sciatic nerve is already split. You notice one larger, more medial nerve, and another smaller, more lateral nerve. Which one is which?
Tibial and contralateral. Tibial is like one medial and contralateral.
Correct. So tibial is a kind of a beefier one that's found more medially and slightly deeper, because when the common peroneal, the lateral one, takes off, it's also called common fibular, because there's a little fibula, so it's going to go laterally. It takes off and goes superficial quicker. So you're going to see this kind of fat tibial nerve, and then this common peroneal just kind of sneaking its way off to the side, and it's usually much smaller. I put this, which one do you block first? It's typically better to block the the deeper one first so you don't mess up your view, because your ultrasound readings will then get altered if you're looking through local. So I typically block tibial and then pick out the common peroneal on my way out because it's more lateral and superficial. All right, so this is actually a true story. The guy survived, did fine, and yeah, that was my first day.
Did you use lidocaine, or what did you use for his block?
Bupivacaine. Bupivacaine with a little bit of bupi just for some lasting pain. But bupivacaine is a quicker on and dense.
So no catheter for that guy?
No catheter for that guy. He was still had sensation, but it was being that he's diabetic and has like vascular back, all this stuff. It was decreased. So his pain wasn't. I checked back on him later, and his pain wasn't an issue. They put him on a PCA and he was fine. So, all right. So this is one that we don't see a lot in residency, but you will get tested on, and something that is just good to know for your arsenal. So it's the ankle block. So there's a 55-year-old woman with obesity and PONV, presents with ankle arthroscopy after multiple attempts to contact the surgeon to ask which part of the foot and ankle needs to be blocked for surgery. You just decide to do an entire ankle block. What 5 nerves comprise the ankle block? Dr. Clendenin. What 5 nerves? Say it. Sural. Yep. Common peroneal. Saphenous. Tibial.
Peroneals too, deep and superficial.
Sorry.
Deep and superficial.
Yeah, deep and superficial. That's my understanding. Okay, I felt like we got to 6. But maybe it wasn't that. We had to check. What's that? All right. So which of the 5 nerves does not originate from the sciatic nerve and therefore would be spared by a popliteal nerve block? That's correct. Now, which 3 nerves are most readily blocked using the landmark technique, i.e. not using the ultrasound? I alluded to this a little bit in the PowerPoint that I sent. You can do landmarks for all of them. If you have an ultrasound, you can block 2 of them pretty reliably with an ultrasound, and then the other 3. I have another good way to remember that.
I think
Your first one was sural?
Sural?
Yep. So sural, superficial, peroneal, and the saphenous. So those are all starting with S, and they're all also only sensory. So they're kind of grouped together in that way. Okay. Your other 2, your deep peroneal and tibial, you can visualize fairly well with ultrasound. And which is the largest of the 5 ankle block nerves? Which one does the most? So I just mentioned 3 that just do sensory.
tibial.
Yeah, so it's tibial. And that one, if you look at the PowerPoint, you can actually see the nerve. It's a beefy nerve, and it's right next to the vessels. It's a neurovascular bundle. So that's definitely something that you'll be able to visualize. Deep peroneal, not as easily visualized, but if you deposit local around the dorsalis pedis vessel, then you will be able to block it. So same patient, when scanning to block the deep peroneal nerve, what important structure do you want to identify, as well as avoid with your needle? I just did that one. The dorsalis pedis are correct. If you're concerned about the efficacy of your deep peroneal nerve block, where should the surgeon check for sensation with his forceps?
First and second toe.
Yeah, do you guys remember that? The webbing in between the first and second toe, that's the kind of the quintessential dermatome of the deep peroneal nerve. It also covers the underside of the foot as well. Turning your attention to blocking the tibial nerve, you place your transducer adjacent to which malleolus?
Medium.
Medial. What is around the lateral malleolus? Close. On the back side of the lateral malleolus is sural. So this one's tough. From anterior to posterior, name the 6 structures.
Same.
From the anterior to posterior. I like to repeat myself. With the tibial nerve block view. There's a mnemonic. I think we just did this in anatomy lab.
No. This is the top of the conveyor nerves area.
Yes. So, tibialis posterior.
The
Flexor
flexor digitorum.
yeah. Then you have your neurovascular.
Vein, nerve,
And what's the H?
Hamasis.
Flexor hallucis. Yeah, good job. It's a mnemonic. I've never been tested on it. You will be tested on it when you go to the anatomy lab. So remember that one. You see several structures that look like they could be a nerve, and you remember that the nerve usually sits very close to what important structure? One of those big and very nervous area.
Tibular.
Artery. Yeah. So a good bet is that the nerve is right next to the artery. We see it all throughout regional anesthesia. But in this case, if you don't see a good tibial artery, or tibial nerve, you're gonna put it around the artery. You'll be just fine. So then the surgeon walks by as you're blocking the patient, states that his incision will be on the dorsal and posterior lateral aspect of the foot. Which two nerves will cover the dermatomes of these incisions? Dorsum of the foot is deep peroneal. Does the we already talked about? Yeah. So deep peroneal is the webbing of the. So when you're looking at the top of the foot, all you see is a webbing covered by the deep peroneal. Superficial peroneal covers the top of the foot. Okay. And then posterior lateral. I think you were tibial. Yeah. Sural is kind of calcaneus. But I was thinking kind of along the lateral aspect of the foot. So yeah, the sural is kind of calcaneus and just underneath the back, and then the tibial kind of takes over the rest. Saphenous being on the inside. Yeah, that's the other one. So which we already kind of talked about some of these, but for blocking the superficial peroneal, what's the technique? It lies superficial to the deep peroneal, which lies close to the dorsalis pedis.
Like anterior to your medial malleolus, transverse, transducer position.
Yeah, you don't always need the transducer in this case. It can be a field block. So the saphenous and superficial peroneal lay pretty close to each other, and they lay on the anterior aspect between the two malleoli. So you can do a field block between those two and knock out those two nerves as long as you deposit enough local. And then the sural, you just wrap around the lateral malleolus and go between the lateral malleolus and the Achilles tendon, and that field block, 3 to 5 mLs, will block the sural. And then the other two are ultrasound.
How deep do you deposit it?
Sorry?
How deep do you go?
Very superficial.
Okay.
Yeah, the ankle.
Yeah, so make a wheel kind of.
Make a wheel. That's exactly it. Yeah. And I usually make a wheel and then kind of massage it in. Because the ankle doesn't hold a lot of volume, obviously. So you're going to just you can put your needle in deep and then inject as you pull back, and it'll kind of create this skin bill that you can then kind of massage in place. All right. Case number 4. 55-year-old man with end-stage renal disease on peritoneal dialysis and history of malignant hyperthermia presents for right AV fistula creation. You're rightfully afraid to do general anesthesia on this patient, so you decided to do a surgical block with sedation. Which nerve blocks are appropriate for this patient? Henry's feeling might miss a little bit. Superclav, yes.
The thoracobrachial block.
The what?
Blocking the nerve.
That's important too. We'll get to that. But as far as peripheral nerve blocks that you would do before, superclav, pretty common. Infraclav, you can still get away with doing an infraclav. And then you can also do an axillary infraclav. Weighing the pros and cons, infraclav and supraclavicular. When consenting the patient, he mentions a past injury of his AC joint, making it painful for him to abduct his shoulder. This in mind, which block should be performed? Why is that? Positioning for the infraclav, you kind of have to live with that, correct. When you place the transducer on the patient's neck, you notice a stop sign orientation of the brachial plexus, more like a stoplight. Orientation of the brachial plexus, sandwiched between two muscles. Which block view are you visualizing? Right. And what do you need to do with the transducer in order to find the supraclav view from there? Move caudally into the kind of the fossa right above the clavicle there. Yep. So you finally obtain the desired view, and your patient points to and asks what the structure labeled D in the picture is. What do you tell the patient? Or A. Oh, sorry. D. Can you see? Sorry.
So it's A.
Start with D and then we'll go to A.
Sure, the rib.
Correct. So D is the first rib. And then what is A then? Correct. Just for completion's sake, what is B? For extra points, what parts of the brachial plexus is this block performed at? For Randy, Travis,
Trunks and divisions.
divisions, yeah. Trunks is interscaping, so divisions is super fun. Good job. All right, case number 4. 55-year-old patient with same patients. Sorry. After performing the block and rolling the patient into the OR, you recall that you'll need an additional block in order to anesthetize the proximal medial arm. What nerve are you blocking, and how do you block it? Isela.
Wait, sorry, I missed the question.
It's the answer that you gave before.
Oh, the brachial.
You were.
Yeah, it's here.
Yeah, it's the intercostal brachial.
Yeah.
Yeah, that's right. So, intercostal brachial is not part of the brachial plexus. It's something to remember, but it's still in the arm. So, in this case, how would you block that, or how would you maybe advise your surgeon if they're already in the field?
With a wheel and a lateral to the axilla.
Yeah, distal. Yep, distal, just on the medial aspect of the arm, and it's a field block, just like you said. No, we don't do that under ultrasound. When you drop 10 mLs, we'll typically get that haircut. All right. So during the surgery, the surgeon has to extend his incision into the medial aspect of the forearm, and the patient begins to moan with discomfort. So medial aspect of the forearm here. Which nerve did you fail to block? And describe how you would properly block this during the supraclavicular block. Ulnar, yeah. So commonly tested is the ulnar distribution in the supraclavicular block. It can sometimes be missed if you don't get into the corner pocket, so to speak, between the first rib and the artery. So it's a little tenuous down there because you got to make sure you're on rib and you're not going too deep in order to hit lung. But that's where the C8 kind of distribution, ulnar distribution lies, and it's important to block. So that's where you would go. You would get. That's how I do my supraclav blocks. Is you get into that corner pocket, and that's where the block starts. That's when you start depositing local, and then you can hit the other targets because that's the deepest structure.
Can you show it on the picture of the side?
So you're going to come lateral to medial. This is first rib. This is artery. This is the corner pocket right here. So you're going to come down, hopefully kind of peel artery off of first rib, and that's how you know you're going to get the ulnar distribution. And then I usually back out, drop a little here, and then depending on how dense of a block, if it's a surgical block versus analgesic, it depends on how aggressive I will get close to the plexus.
That wasn't for you, that was from the dumb person.
And like, Jake, how do you do that? Do you like go over top of the nerve and
I scoot under. So, yep. I typically come here, and when you get close to the plexus, I do a little hydrodissection. So you'll have aspirate, inject, and you'll push this up, push this up, push this up, push this up, and then you'll get into this place where you can push it all up. So it helps to have a good block assistant for that. And it's a little scary, but if you have this first rib and you know it's the first rib because you see thorough deep to it, then you know you have a backstop. As long as your needle's impeded. All right, so 59-year-old patient with severe COPD on 5 liters of oxygen as well as chronic pain on Suboxone who presents for left distal radius ORIF. We'd like to offer an analgesic block for this patient. Which block would you choose? Block. Okay. And why are you thinking those?
Less incidence of catching the phrenic nerve and decreased incidence of pneumothorax.
So yeah, axillary would kind of knock both of those concerns out. Infraclav, you still have a small but real risk of that. So yes. Does everyone understand that? So the more proximal your block, the higher the risk of phrenic nerve palsy with a patient on 5 liters. That's going to be a problem. So infraclav, axillary, both options. You're positioning the patient for an axillary nerve block. Where do you place your transducer to have an optimal view of the block? Excellent.
Yeah.
It's holding up wrong.
You're pointing to
where it is.
It's hard to describe medically. Yeah. So it's you can kind of think of it as like transverse to the arm, but with the arm abducted out, and it's just distal to where the pectoralis kind of take off. So you kind of want to catch the biceps, kind of underneath the deltoid, and it's really in the patient's armpit. So in the axilla, sorry. You're going to want to clean it up really well for infection risk and everything like that. So good. We don't do many of these, so it's important to read up on it, okay? Because you will still get tested on it. So you're able to identify 3 nerves around the axillary artery. What are these nerves? Yes. So these are what part of the brachial plexus? Branches. So yes. So radial, ulnar, median are the branches. And so what is the optimal position of the patient for their arm for the axillary nerve block? We kind of already discussed that. Abducted. This is a repeat question. Sorry. Oh man. This is a sorry. I guess I sent myself the unedited or the wrong. So my last question, and this is an important one for a test question, is you have to block one additional nerve outside of the 3 that you see around the artery. And that nerve lies in what important structure? Or what structure does that nerve lie in that view? Yes. So the brachioradialis, the coracobrachialis is the muscle. And what is the nerve that lies within that muscle? Musculocutaneous. So they will commonly say, what is the nerve that needs to be blocked in addition to your typical nerves in the axillary nerve block, and that's the musculocutaneous lying in the coracobrachialis. And you can actually, if you scan more proximally, you'll see it kind of come into the nerves, and then as you scan distally, you'll see it take off into the muscle. And it does take a completely separate needle pass in order to block it. So that's definitely like the quintessential axillary nerve block question. Any questions? All right. Well, for the sake of time, I was going to run through some of these with the ultrasound, but I feel like with the roads how they are, and you guys on the schedule, I kind of
Because I'm so mean.
no. I also don't don't want to drive home too late in this weather.
He's like, I'm awesome.
No, when we're on together, we can play around with the ultrasound, find these nerve blocks, because we don't get to do all of them, especially axillary and stuff like that, ankle as well. So, all right, good job, guys.
Stand up at the stretch, and then we'll have Dr. Todorovich talk to everybody and answer some questions if there are any questions. Go from there.
Thank you.
Yeah, thanks.
This is really good.
Did you guys do that show once again?
I mean, I hope. I spent a lot of time on that. Yeah.
Yeah.
I sent it to all of them. Oh, you got it?
I got it.
Okay. Well, that's right. You get the sit.
I mean, I'm not going to go.
Yeah.
Sorry, where are we?
I was gonna send it. I can send you that without in like kind of you have us to do this. That's why we're here.
What's that?
He lives on blocks over in Billy, where he's a safety guy.
Eric and my tinnitus guy.
Really?
Troubleshoot.
I've watched
I know. It's like, I don't know, work this time. Yeah. I guess that's not just Googleable. We're also, yeah. You tell me what I'm doing here, and this requires that sort of it helps that you're fresh. You're still good at one. You're getting close to the other. Oh, are you? That's like the most common thing you hear. Show your hands. Show your hands.
What am I doing wrong? It's like, I wonder why.
As much with that. But you play music, though, right?
Yeah, I do.
Your email?
Yeah. She's a little bit.
Yeah, I think those are, it's kind of distorted by the logo because you do the picture kind of at the yeah. I like that. Right. Exactly. Yeah. Yeah.
No, that's right.
Higher with it wasn't prepared for but it was only
How many positions did you do? One fellow. I think you're perfect. You're a fellow.
I'll sit next to you.
You want me to, or you want to start?
All right, we're going to go ahead and get started, guys. Grab some drink, food, whatever you need, and have a seat. There should be.
There's only cookies.
What?
And
God. Well, E-Type is supposed to bring it, and it's supposed to be on it's a standing order.
we just cast our new chief, Ted Timothy, with you tomorrow.
Thank you. Awesome. You did a great job for this.
Yeah, but you walked in and you were not sandwiches.
But who brought the cookies then?
Those are like always here. They're
Yeah, so cookies and drinks are together.
and I don't know who brings those.
I don't recall either.
So maybe we should have somebody on staff.
Somebody else brings them. I don't know who it is.
Maybe a staff member can help with that. You know, it's not how.
Well, Sarah orders it. Okay, so we'll figure it out. So the last 2 weeks, you said, Kim? Okay. So we haven't done one of these this year yet. We have been doing resident chair meetings, usually a couple of times per year. We try to do it every other month or so. We were scheduled to do it last month when we had our last snowstorm. And that was actually part of the reason why I wanted us to just stick with it today, because I didn't want to have a second one pass by and not be able to talk to Dr. Todorovich and either view or bring up frustrations, concerns, things that are going well, things that are not going well, that sort of stuff. So really the purpose is it's open-ended. It's also time for us to make announcements from a department standpoint, if there are any to make. So without further ado, do you want to?
Yeah, I can start. Thank you so much for coming. So a couple of announcements. You know that Highlands Ranch is up and running. We may not have all 11 anesthetizing locations active every day, but it is ramping up pretty fast. You guys are not going to be asked to go to Highlands Ranch. As of now, it is not a training facility. I don't know when and if it's going to become one. If they allow us to have you guys go, then Dr. Oliva and I will sit down and discuss what type of exposure would be most beneficial for you guys. We think some kind of outpatient / leadership rotation would be appropriate if we were to go there. But as of now, that is not the case. I think that there is some movement to make Broomfield into a training site potentially. ACGME office is getting involved, and I think that orthopedic surgery is getting permission to at least send a fellow. So I'll let you know how that goes. But as of now, you are not going to go there. And another new development as of next summer is that we are actively negotiating to get Cherry Creek on board, which would be outpatient facility, kind of a boutique practice. Again, none of you guys will be involved with that, but you will hear about it. So if you have any questions, let me know. There are 6 anesthetizing locations at Cherry Creek, and we are currently negotiating to have a pain clinic site there as well. And then for some of you, it is going to matter that we are getting AIP3 on board as of 2022. I don't know exactly when during 2022 that's going to happen. I think it's late spring, early summer, but I could be wrong. This is additional 12 operating rooms. We will have most likely CTICU moved to that new tower. So when you're in CTICU, you may be assigned to go there. There's no coverage back and forth because it's almost a mile walk from AIP2 to AIP3. So when that comes on board and you get assigned to be there, this is going to be a different site, different board runner, different lounge or a place to eat. Do you have any questions about the expansion of our clinical facilities? You know, by the time everything is said and done, we will have 30 plus additional anesthetizing locations. A lot of cases, we've done about 42,000 cases at UCH alone last year and 35,000 cases at Children's Hospital. And then I don't know exactly the number of cases at the VA and Denver Health. So you guys could be exposed technically to over 100,000 anesthesia cases a year. So there's a lot to learn, a lot to see. If there are any particular cases you want to do once you're done with the requirements, just talk to Dr. Oliva. We want to make sure that this is a good educational experience for you guys. We will continue to hire advanced practice providers so that we can pick and choose what cases go to you. We have right now 120 plus APPs on the UCH side alone, and about 40 plus on the children's side, plus Denver Health, plus the VA. Do you have any questions about that part of the announcement, the clinical growth, expansion, type of cases, number of cases? It is a lot.
I think one of the questions people on the interview trail are asking is, why don't we get bigger as a residency? And the answer to that is there's really, I think, a balance between making sure that we don't expand to the point where service obligations are the priority and trying to maintain a semblance of a balance between education and clinical service. So there's no plans to increase our number despite the fact that UCH wants us to increase our resident size.
How many hours will be in AIP3?
12.
12. And I think that the plan is that CT cases are going to go to AIP3. So when you're doing your CT rotation, CT ICU, anything CT related, it's very likely you'll spend the bulk of your time on the AIP3 side. The interviewing season, and Dr. Oliva can tell you more about that. As you know, we received 1,400 or about applications for 18 slots. Dr. Oliva had some basic criteria to triage it down to 800, 850, and then manual triage with the committee down to 130 or so applicants. I make a point, if anyhow possible, to see each and every applicant that comes through the recruitment process, both to Dr. Oliva and I. One thing that comes out over and over again is that the candidates are incredibly impressed with your engagement. Coming to dinner on Sunday night or Sunday evening and taking them around and doing lunch with them on Monday. So I would like to take this moment to thank you from the bottom of my heart, because you are our most important recruitment resource. You really are. They learn a lot from you. They like that you come in large numbers. They like that you come with family members. They really like that. They like to see your kids. They like to see your loved ones. So they like the choices of places where they eat. So that's another plus. So you keep up the good work. That should be that difficult to ask you to continue. But it is really important. I know sometimes it's too much to ask. Sunday evening, you just want to unwind, you want to be with your family. But we really appreciate that effort you put in. They like that it's not scripted. They like that you mingle around and talk to them. They like that you're available and able to answer any matter of question they may have. So keep up the good work, and thank you so, so much. It matters to us. Better candidates we can get, better it's going to be for everybody. Your colleagues are going to be good ones to rely on. It's a nice family type atmosphere we would like to foster. Do you have any questions about the recruiting process? Anything that you think we should change halfway through? May not be easy, but we can certainly listen. Anything you think that they ask that we should make available so that they can get that information from the either brochure or email or website or?
I've gotten asked a lot, like what the difference between the 6 and the 4 week rotations, and I'm like, I don't know.
Yeah, we address that when we do the orientation on Monday. So if you're getting that question at lunch, maybe they didn't pay attention, or maybe they didn't understand it right.
They were nervous. So.
But we're covering it. I mean, the gist of that, just so everybody's aware, is it's a transition. The idea is that we move towards 6 weeks across the board, but we couldn't do that for this academic year because we didn't have enough numbers.
So I guess referring them to the slide presentation.
Sure. On that note, I had a couple of questions about class breakdown, like married, single, children, and I assume that's covered in your slide deck, but it was.
Mario, I think, does touch on it. I don't know to what extent, though. I don't know if he actually breaks it down according to percentages or numbers, but he does talk about how people have families and how we have residents that take maternity leave, paternity leave. So that is part of it. Do you think it'd be helpful for them to actually have the percentages?
Some people seem to want hard numbers, like percentages.
Okay. I'll tell Mario to look at that if he hasn't already.
Would you guys like to get that information as well so you can share that with them? Maybe Dr. Oliva can send it to you in some kind of a PowerPoint or just one slide, demographics, because it's completely transparent. We have nothing.
People want to know that there are other single people that everybody that had kids, and then people with kids.
Yeah, sure.
Kids, so they can hang out with them, so you like. They want to know the numbers. They really
Makes perfect sense. We can certainly provide you with that information during the interviewing season, so you get the updates as to who got married, who didn't, and who's got another child or no kids. That would be fine, because if they really want the hard number, it would be good to equip you with that information also.
I have to admit that I'm impressed with the numbers for the turnout. I don't know if the CA2s and 3s can feel that increased number of people showing up for the dinners the night before their interviews. We're seeing that definitely on the price tag, so thank you for that. But I want to say that I'm impressed, actually, that so many people are going first. But second, that we've had now, this would be 5 dinners in a row. We have 2 more in this kind of first batch of interviews. So it's a tough stretch. Thank you for continuing to go. There's 2 more next Monday, and then the following Monday, and then we have a break for about a month. So you can kind of catch a breather for that.
We have about 20 plus of our own folks come to these dinners. And the candidates are impressed that there is more of us than them. They also watch how you interact with each other. They watch how well you know each other and their spouses, or your spouses, the kids. So all of that, interestingly enough, matters to them. So they always bring that up. So I wanted to take this opportunity to thank you. I know that sometimes it's too much to ask because you already give a lot, but it does matter to the quality of our program, and it matters to the information we provide because we want to be open and transparent and as informative as we can be. Because they are making a big decision. You all remember being in their shoes. It's a big decision for the family and for them. This is pretty much all I've got. You know about the global health rotation that Dr. Oliva and Dr. Simmons have started a couple of years back. We had one resident last year. We have one lined up for this year. It's a 4-week rotation that we plan to offer every year from now on. We have a spot for one, and certainly if there's a huge interest, Dr. Oliva and I will talk about it and try to figure it out. So far it's been Uganda, but we're also looking at Guatemala as a possibility simply because our school has a very large presence there, so it may be easier to use the existing infrastructure that they have in place, but that is to be determined this year. Next year is going to be Uganda again. Do you have any questions for me? Anything you want me to go over? And as Dr. Oliva said, anything that bothers you, homework for me, things to focus on. As you know, it's a never-ending improvement saga that we focus on. We don't have it all perfect, but we'll die trying to make it perfect, I like to say.
Any rotations, any sites, any issues that have popped up?
Any changes that you would like to see that you communicated with us that did not happen or seem to be seemingly are ignored?
The one thing that I noticed that really helped stick you is a rough rotation. First thing, we didn't get like formal eval for it, but having the intern actually be there was tremendous.
Really? Our intern or any intern?
Ours.
Wow.
Yeah, I mean any intern.
Beggars can't be choosers, right?
So one of the questions I got a couple of times was, are we going to increase our categorical spots? Because if that happens, then we can have an intern there and really help with it.
So the answer is yes. We, for this next match cycle, won't have that increased number. This time next year, we're going to the hospital for a proposal to increase that number to 12. And that way we would have virtually a continuous presence of interns on all of the services, including the SICU.
So, there were two issues that Dr. Oliva wanted to focus on when we talked about it. Number one is funding, of course. We need to talk to the GME and the hospital leadership. But second, he wanted to make sure that the integration that he's working on right now is working well because, as you know, we have 4. So getting rid of some of the rotations, adding some, such as having an intern, we needed to make sure that it's going okay before we put in the mix 12 people all together. So it's going really well. I think the folks like it. So
yeah, the interns next year will do, so they, as you remember, when you were an intern, you did 2 MICU months. Yeah. So this year they're doing an MICU month and an STICU month. Next year they're getting rid of the MICU completely and they're doing a CTICU and a STICU month.
So you're going to have help in every unit
right.
moving forward.
I mean, I would echo that for APS. I did not have an intern on APS, and it's just kind of a grueling rotation to be here till 7 p.m. 7 days a week, 3 weeks in a row.
It is.
Yeah.
And
rounding
like
on
when there's an intern on, you're alternating, which would just make kind of the tolerability of that just a lot better.
Yes. You've gotten the short end of the stick many times already.
You have a black cloud above your head, right?
I did not schedule the APS schedule, so I cannot take credit for that.
Well, there's only 4 people that get that help, right? So it's not like it's the norm or expected at all, but
That's
like
good
it
to know.
would make a big difference.
That's good to know. And who knows, eventually we may decide to have the exact same number of categorical slots as we have for everything else, like a lot of programs do. Although it's good to have this little wiggle room to have some of the CA1s who decided to switch or do something else. Another thing, you go for that. Okay. I know the Dr. Lehman doesn't want to fill every slot. Another thing I was going to tell you, I know you mentioned APS. One weakness for us has been that when we started the APS, we didn't have a through rounding service when I came, which meant that people would ad hoc just run as needed, and especially ICU, but not really for all the floor patients. And I got pushback from the surgeon saying, well, you enjoy sticking it in, but you really don't like to follow up on your patients. So, there's a lot to be said about that. So I think that now having APS allows us to really round on our patients and take full responsibility for the care from the beginning to the end. Having said that, though, when we started the APS, and all of you've seen that, there's a lot of calls and consults for chronic pain patients when there's an acute pain on top of a chronic pain where nobody knows what to do. And our APS attendings are not trained to handle that. You don't get the kind of training you need to handle those very complex chronic pain patients. So far, as you know, we reach out to chronic pain fellow, we reach out to chronic pain attending. We have one candidate right now, chronic pain faculty potentially, who is really interested to build that practice. So the plan is, and we are actively negotiating and talking, is to have that faculty, if it's to work out, to actually cover that side of the service as well. So you don't feel sometimes lost as, what do I do now? We've been pouring narcotics for the last 4 days and we cannot send patient home. So I'm hoping that change would allow some medication management to come in place. So, and then for you to get more education as to how to handle these patients on the floor, because our colleagues, surgeons need help. They are done with the operation. They really need to discharge the patient, but they can't because the chronic pain gets in the way. And hopefully that faculty can help with pre-procedure assessment, before when they come to a pre-procedure clinic, that they could be optimized. If there's a block that needs to be done or a catheter that needs to be placed or a stimulator, so that they're optimized for the surgery. Do you have any other questions, any other concerns you would like us? I really mean it. I really want to know. This is not just going through the motions.
Is it true that they're working on getting an APP overnight in the sticky as well?
They are. They've been working on that for quite some time. They were hopeful that this winter they might be able to have enough staffing to start doing that, but they've had 1 or 2 people quit, and so retention of those folks is very difficult. So I don't know when that's going to happen, but that is still the plan.
Just to remind you, they are not under the umbrella of the Department of Anesthesiology, as you know. They are under the umbrella of the Department of Surgery, so we don't negotiate the number of spots or the cash flow or anything like that. So, Dr. Solomon works very closely with the surgical department, but we have no control over that. They don't report to us, and they're not hired by the Department of Anesthesiology. But yes, they are very well aware of that. Very well aware of that.
Well, if there's no other questions, I just have 2 comments. One is a reminder for the holiday party that we have next month. If you haven't RSVP'd, please do. That's a fun thing for the entire family to go. If you went last year, a lot of families show up at that. It's really a focus on our department, so they had a really good time. And that's, I believe, on the 20th of
December. And again, we have our own exhibit. It's a different exhibit than last year. So if you've got kids who would like to see something different, they're welcome to come. And this time we got a feedback last year, two things. One, people didn't like that we did not have music. So this year, as I told you, we're not perfect. We're just making it better. What do I know? I thought music would be a bit much, but I was wrong. I thought I would have talked to people. I don't want this blasting music, but maybe it doesn't have to be that loud. So we are going to have a DJ this year. We are going to have a dance podium this year. So you're welcome to dance to your heart content. I think the event is from 6 till 9. I think the music will start at 7. So you can say your hellos from 6 till 7, and then it's a dance time. And the second thing is people didn't like the fact that food was not served till 7 o'clock, meaning that for an hour people had drinks but no food. What we were told is the food can be on display only for 2 hours because it's a buffet. So it's a state regulation. So they said that now they're going to start serving food at 6 and will remove food at 8. FYI, we have about 450 people who RSVP'd so far. So you're welcome to come. Bring your loved ones, bring your kids. Let's have fun.
And then my last announcement is I'm going to be sending out an email probably either later tonight or tomorrow, letting you know that there is a CT fellow who has abruptly resigned. Ryan Harkins has put in his resignation effective immediately. And so we're trying to look at what our options are as far as staffing the CT rotation. The hope is to try to minimize the effect on the 2 remaining fellows, but also on the residents for the remainder of the year. So we're going to try to test some things out, but I want to make sure that you know about that. If you have any questions about that, I don't really know the reasons for the resignation. He hasn't shared that information to anybody. And so he's being provided with resources, so hopefully if he feels comfortable, he'll reach out to somebody at some point. But that's going to obviously put a kink in some of our scheduling. Yeah.
Mm-hmm.
I'm surprised he's.
Yeah.
We're very surprised as well. Yeah, I've heard nothing but great things about him.
Yeah. And as Dr. Leva said, we're going to be there for him, whatever the reason is. We'll provide him with all the resources he needs to move on. But we agree with you. He was fantastic.
I was working with him on CTICs.
It's a huge loss.
The night shifts.
Yeah.
On CTICU can be pretty dangerous sometimes. I was talking to some other attendings who do ICU, and they said when they did their CTICU rotation, they would always be with a CT fellow, or a CTICU, or some critical care fellow with them overnight.
Yep.
Times.
Yep.
I've been in situations where pretty scary stuff is happening, and it's just me, and there's no one close by to get help. I was wondering, is there any plans to get their second provider, or I know it's going to be hard, especially not having another fellow, but is there a plan to change that in the future to have someone help for night?
Yeah, so that's been kind of the screaming that Brendan Sullivan on the CT ICU side and Jason Brainerd on the ST ICU side have been screaming at the hospitals, saying that it's unsafe for the patients, it's not fair for the people that are in-house in those situations, and that we need to make a change. They've been very sluggish on their end in terms of coming up with money for the solutions that are needed.
I hire more APPs, in particular experienced ones. It's very hard to find experienced APP in CTICU. The pool is very small.
And on top of that, the idea of throwing more residents into those situations is something that's often asked from administration, and that's not, from my standpoint, going to be a negotiable piece, because we share both those units with surgery, yet we have more of an obligation from a manpower standpoint for those units than they do. So unless they're going to pony up more people, I'm not going to do that.
And having another colleague at your level of experience, what good does he do just torturing 2 of you at the same time as opposed to 1 at the time, You just need more senior person, more experienced person to reach out to, not another CA2.
Yeah, I do think that one of the solutions in the long run is to have that intensivist in-house. The MICU intensivist is in-house. To me, that is the best solution.
Because I know at the CIC, they would literally come in every night, so they literally just changed it to where the cardiology fellow has to be here overnight. So that was a solution for them.
Yeah, that's been a long-standing problem that we've been trying to work out for a long time.
We're also talking about increasing the size of the fellowship from 4 to 5. So that may allow one more person to be in the pool to take call. But that has to be approved by the ACGME office first. So there's a bit of a process to do that.
All right, without further ado, let's get going with Journal Club. Yeah?
Thank you, guys. You know where to find me. I don't know what's going on with my pizza wow pow, Timothy.
Do you know?
I haven't gotten signed out on what's
Yeah.
that yet.
It should be Brooke and Mike that are
Oh, that's right.
coordinating
That
it.
change
So they
has
haven't
not happened yet.
really signed out yet.
Okay, yeah, you are out of
I want to find out
sandwiches and my pizza. Don't forget, 4 or 5 of you once a month. There's a standing invitation. It could be more than 4 or 5, but I've got pizzas to serve. So, and it's a good time to talk in a small group setting. Thank you guys so much. If you think of anything that matters or that you did not share with me or you want to share in a more private setting, please let me know. You know where to find me. I say my door is always open, but it's never open because somebody's always in my office. So just reach out to Terry and we'll figure it out. Thank you so much.
Thank you.
Thank you so much.
There's a few more cookies left. You guys are up for it. I don't know. All right. So I see a couple people who've been at the Journal Club with the new format before. Quite a few people here actually. So did some or majority of you get a chance to look at the article? Okay, we've got enough people now where we can split it up, so we'll just go by table. So we've got a couple learning objectives that I'll go through, sort of what we hope to get out of it, and then the paper is sort of a means to that end. It's a way to discuss something that commonly comes up with research. And then we kind of have 4 tables here, so we'll just go intro, methods. Yep.
Do you want to keep the same?
Oh, we got assignments?
They were assigned,
Okay,
yeah.
perfect. So keep your assignments. We don't have to ad hoc then. I didn't see that one. So that's great. That's the ideal scenario. Otherwise, we can do it the other way. All right. So a couple of learning objectives. We're going to look at this retrospective cohort study. Sort of one of the main study designs that you'll see. We went over a clinical trial before. The other end, if you can't randomize patients or prospectively enroll either for cost reasons, maybe it's not ethical, you need other ways to ask questions and get meaningful information out of available data. And one of the more convenient ways to get large data is through billing databases. So you can get large numbers. That's what this paper that we're going to discuss is about. You can look at something using data that's already collected for another purpose. There's some benefits and some weaknesses with that as well. We're going to talk a little bit about composite outcomes, sort of why would you do this, what are the ramifications of that, and then look at sort of what's going on with population data like I was talking about. So
just collecting data on a lot of people. That's sort of a convenience sample, and where you can get a retrospective study out of it, and then just have somewhat of an understanding of what propensity matching is. So when you see the phrase, you can recognize what they did and what they're trying to tell you and convince you of with that when you use propensity match. And then just talk about advantages and disadvantages about retrospective studies. So this is our paper. It was last month in anesthesiology. It's one of the bigger studies in regional anesthesia that I've seen. I've been following the literature for a while. Typically, they'll do clinical trials that are like 40 patients, maybe 60. A few of the larger ones get into 300. But before this paper, I hadn't really seen anything in the tens of thousands. Have you seen anything? So this is kind of a landmark paper from that standpoint. The methods aren't novel, but the topic is. So I tried to distill their hypothesis down to this one sentence. So maybe the intro. Who had the introduction? You guys are assigned to that. Would you agree with this, or is there another way that you would distill down the central question, right? So like when you design a research project, I try and bring it back to actually what you would do if you wanted to answer a question in medicine or research or related to anesthesiology. But what were they trying to answer? Why bother with this paper at all? You think of anything I left out, or what else were they trying to answer?
Just the background of it was that there's an increased number of peripheral blocks happening in ambulatory surgery, and sort of like we don't have a whole lot of things to say that it helps or it doesn't help.
Yeah, that's a really good point. Like that, the why. Why would you even bother doing this? Sort of what is your question? Oftentimes when you're designing studies, though, you have a directional hypothesis. I got the general because this is sort of a broad paper, but you have an idea of what you think is going on. And I think their assumption is that peripheral nerve blocks are good, that people are paying for them, they seem to like them, it's sort of a low risk. We should see what it does beyond just sort of our clinical gestalt with that. Okay, so actually let's go through the introduction first, since we have people assigned to that. Purpose of the introduction is to frame the research in sort of what's been done, what's missing, and then how this paper is going to address that. So could you, let's see, I forgot who was in the group, but someone mind speaking to that?
It's just two of us.
Yeah. I think we got three. Yeah. So what do you need to know to understand those sort of the background of this?
So just basic context. Talks about nerve blocks, why they're good. It says that it mentioned something about how we have good data showing that in the short-term period there is like a proven benefit, but they wanted to look at sort of greater context and longer-term outcomes.
Is there anything else you need to know? So what's sort of the current status of the literature? Do they go over that? They must have reviewed some of the other studies.
Yeah, so I'll just quote directly from it. It says, recent systematic reviews suggest that nerve blocks provide the highest degree of acute postoperative pain relief in shoulder patients. However, quality evidence supporting a positive impact on longer outcome is high.
Okay, good. So they're getting at that question of sort of what's missing in the data, right? So they're putting forward that regional anesthesia is the gold standard for acute pain management. It's probably pretty reasonable. So the meta-analysis supports that, but no one's looked longer, right? So they get blocked, they go home, surgeons follow up with them on a schedule, but we don't really know sort of what happens with the blocks. Okay. Anything else we need to know in the context of that? I think that's probably most of it.
Bigger context is important too. The way they were talking about like 25% of unplanned admissions after shoulder surgery they think are related to like anesthetic delivery during the surgery. That number initially sounded like kind of astonishing.
Yeah.
So I think that when you say that, like continuing to dive into the data further to look at 7 and 30-day admissions, and if they are in fact related to that, I think it's important.
Right. I think you bring up a good point too. I think this is a blind spot in our specialty in general, right? So we take care of people in an operating room, which have profound implications, and yet we don't know sort of what those are, because for the most part, patients do extremely well. But if there was a 1-year change depending on your anesthetic technique, I don't think we'd be able to capture that necessarily, because there's a lot of compounding there, and it's not really being collected. So I think it's starting to try and address that and see if one of these interventions that we do. The other important thing is there's a cultural context with that and sort of a changing landscape with how medicine is practiced and reimbursed. So geography is important here. So where did they do this study?
Canada.
All right. So what's one of the big differences that changes the relevance of this paper between Canada and the U.S.? Why readmission matters?
Universal health.
Yeah. So they've got universal health care right in Canada. So readmission matter. They're very interested from like a patient standpoint, but part of the interest potentially in the United States is that if they're trying to go to bundled payments or trying to have their readmission for complication could potentially be factored into hospitals losing money as well. So I don't know the details of that, but I know that there's this discussion that you get a knee done, here's your pot of money, and any problems that happen are just deal with it. This is what you get. The idea is to sort of control costs and incentivize quality, which is a very simple equation, right? It's best care for the least cost. So trying to incentivize that. So that's relevant from the readmission standpoint. What about I think that's pretty good coverage on the intro. Methods, assigned group. Yourself, any friends? Yep, two? Okay, good. So you'll see a flow diagram a lot. Will you take us through what they're trying to summarize and tell us?
Yeah, so it was a retrospective cohort study from some database that they have access to in Ontario, Canada. So like it says up there, collected from 2009 to 2016. And it sounds like they basically used like diagnosis codes related to shoulder surgery to collect the patients. And then they also used diagnosis codes for the nerve blocks to then distinguish them into whether or not they got a nerve block. Yeah, it's kind of the basic design.
Okay, yeah, you can see that here. So this is actually pretty methods heavy. We don't need to go all the way through it, but I'll at least give you a tour somewhat because we've got. Okay, arrow. So you start with 60,000, right? So in Ontario, they found this. We got 3 years blocks. The main part we'll focus on is this to answer their main question. You got a nerve block? How'd you do? No nerve block. How'd you do? They also did this nested clinical validation cohort. So let me pull up kind of the paper so we can go through a little bit of that. That's editorial. Okay. All right, let's take a look at what they're talking about. Did you read through some of the stats beyond that? Do you have anything for us?
About the nested cohorts?
Well, hold on. We'll go from the top, right? Let's put you on the spot. So we've got a cohort, right? It's 18. First of all, who is it, right? So we got 18 years and older, shoulder surgery, right? That was in our flow diagram. And this is an epi-style study, right? Because they talk about being exposed to a nerve block. What does this do to you? So that's some of the language around an epi study.
Yeah, I mean, so it's based on my husband's in computer science, so some of this was like sort of familiar, right? Like part of the advantage of specialized healthcare is they have all these like very complete databases that they can query. And so I felt like a lot of the stuff that they talked about is just making sure that their query algorithm is like sensitive and accurate. And so it seemed like they kind of, what my impression was is this nested clinical validation cohort was where they sort of cross-checked their query against like hospitals' records of like who got a nerve block and who didn't. Yes. Was my impression.
Right. So did they manually review or is it local data? So the idea is that billing data is just basically a big box of receipts, and they go through it and see what people were charged for, and then they try and figure out what was going on clinically. The flip side, this nested cohort, is they looked at 320 of patients they had access to that wasn't just billing data. Then they looked and said, okay, here's the bill, and here's what actually happened in the medical record. And so it's sort of, that's the cross-validation, saying, look, we think the billing codes are this good, and so therefore, even though we only checked 300, you should trust us on the other 60,000 as a match. Which actually is pretty reasonable, because it's really labor-intensive to go through chart review, check. Even 300 is a Herculean effort. I don't know if the med students are involved or someone did their job or they only did this. But that's a lot to go through. especially too when they talk about they went through 600 variables, I think. And also the reviewers tortured them, which we'll talk about in a little bit on the resubmission. But besides all the fancy methods on top of that, they had one question. So you always want to look at the primary outcome. That's sort of designed. This is what the study is designed to answer. We'll get as much information as we can to try and support it. But what was their primary outcome, which is the one we care about most?
So primary exposure was received under plaque.
Right, but then you need an outcome, right? So you do something to people and then watch what happens.
So
yes, that's probably. So the composite endpoint, right? So what is a composite endpoint? It's part of one of our learning objectives. You'll see this used a lot. So what is it first?
So they take like the number of events of like several things and count that all into kind of the percent. For this, it was unplanned admissions, ED visits, and readmit or death 7 days. So all of those together.
So it sounds super messy. Why would you mix all my variables? Give me one number.
The outcomes are rare enough that if you just did one individually, you would not be able to power your study.
Yeah, so power is a good reason. The other way is thematically it can make sense. So the very common one is the MACE, the major adverse cardiac endpoints. And the idea is that all of these are terrible. If you're a patient, this is really bad. You could put in stroke, MI, death, composite. So then you get more out of the same amount of data because you're saying we're interested in all of these together. If any one of these things happen, we're going to consider it equally bad. Pretty much. So you do extend the power of your study. So that's sort of the idea behind a composite endpoint. There is some debate as to whether we should be doing this at all because oftentimes you won't see a mortality benefit, but some of the other maybe less important or less critical ones are what drives the significance. So this can also be a game that pharmaceutical companies play to get their drugs approved. And so it may or may not be valid for whether you're getting a benefit out of that. That's a different discussion. But always look at what is in the composite endpoint because if they stuff different things in there that don't match, we can all agree that MI and stroke and death are bad, but if they're like MI, stroke, and then glucose over 220 or something, right? Like if something doesn't fit, it can drive the significance of the study. It's not necessarily valid because those don't carry the same weight clinically. All right, so we figured out the cohort part. We've got the exposure. We've got the outcomes. So another issue with the method. So we've got our primary outcome, which we're probably reasonably powered to look at. They also took the 600 variables. But what's a statistical problem when you look at 600 different things? You guys heard about this issue?
Over-adjust.
Or you can over-adjust. Yeah, so you can adjust away pretty much any effect. So the more stuff you put into a model, it'll start to break, right? Because the idea is that you only have so much information. And the more things you include, the less you can tell the difference between groups. And that'll be relevant when we get to the results. The other part of that is when you do a lot of statistical tests, when you argue that a p-value of 0.05 is significant, if you just run 20 tests, just by chance, 1 in 20 of those are going to come up. So if they ran 600, the different variables, you're going to have it's called a false discovery rate. So a certain amount of those will just randomly be significant. So it doesn't really help you answer your question, right? And you don't make a very good argument, which is why they limited it in their analysis to just two of the primary endpoints. The rest is sort of idea generating, and the other one is what they actually tested. So one way that you can get around that is you say, okay, we acknowledge we're doing a lot of tests, and that's we're going to be significant by chance. We're going to split a p-value of 0.05 between every test we do. So there's a penalty for running a bunch of tests, which they did, and that's got a name. It's called Bonferroni correction. So they limited it to 2, so you cut your p-value in half. They both share it, and they met that threshold, and they decided that before. You look not convinced.
Just confused, I guess.
Right. And part of that, just to step back a little bit, statistics can be kind of overwhelming and confusing. Why are there so many different tests? What are we even talking about? Statistical analysis is just an argument. And so there's a couple different theories about it, but the most common one is a frequentist theory. If this is really uncommon, you make an argument that our result would be really uncommon. It would only happen 5% of the time. You should believe that it's probably true, right? So that's the argument. Now, if you say we looked at 20 things and we split the p-value, this would only happen by chance 1 out of 1,000 times. A little more convincing, right? It's still just an argument. You don't know. That's why reproducibility, like doing the same study again, if you get the same results, that's more convincing. Meta-analyses where you have 10 clinical trials, right? That's the other thing I like about clinical research. It can't really get scooped. You can just add to the literature. It may be not as novel, but you can put them together and sort of have more evidence for it. But that's the idea behind this Bonferroni correction for multiple comparisons. The other thing is if they can look at 100 things and just cherry pick what's significant, that's also done, which is not appropriate either. But you need to make a good argument. That's all the statistical analysis is. Okay. All right, and then we're going to, okay, we won't get a sensitivity analysis is where you add different things in the model and you try and break your result, right? So they get a primary result and then they try a lot of different iterations of it, see if they get the same answer. And so if you do, then that's more compelling as well. We don't have to get into post hoc. That's probably enough stats for today. Okay, so results. Let's go back to the PowerPoint. Who's in the results group? Oh, actually, let's talk about propensity score. Just one slide. Sorry. What's the idea behind a propensity score? You guys heard of that term? It comes up in these retrospective studies quite a bit. It's another argument. They're trying to convince you that they have the right answer and they screw up. So one of the problems with retrospective studies is, especially population-based, everyone goes into that. So you don't know if you got a nerve block just because the anesthesiologist you happen to have, what day it was, or maybe there are 4 first starts and you're number 5. That all gets lumped in there and you can't tease those apart. So the idea of a propensity score is looking at, right, the probability of you being assigned to a group. So the idea is I take someone as close to you as I can find who had an exact opposite, right? So someone got a block, someone didn't. You guys are the same age, same weight, male, female, whatever they can think to propensity match on. And then they try and control for that. So this is the way you do that. So unless you're going to design, so they won't go into too much detail so we can talk more about the results. It's a pretty methods-heavy paper, but if we just focus on the primary outcome and sort of what goes on in a retrospective study, I think that'll be good for today. So the results group.
Sure.
What do we have at table 1? It's usually demographics. So what do we have? What are they telling us?
Basically, they're saying that, yes, between the nerve blocks and no-nerve blocks groups, they did their best to try to stratify them into equal distributions.
Yeah. And so let's look. Did they match? Just by random 30,000 in each group. That's pretty good. It looks balanced, right? Everyone's about the same age. Gender similar. It looks like fairly well matched. I don't see anything that differs too much. So I think that's pretty convincing that we're comparing similar groups. Is there anything else you would want to see in this table 1 to convince you that the patients are similar? They've got the type of surgery that's important. The approach could matter for pain, right? Arthroscopic versus open. Everything else that represents
Small bases, yeah.
Yeah. Seems pretty complete.
Chronic pain history.
Is that in there?
Like drug abuse,
Drug abuse, alcohol, I don't see that.
I think I would have.
Right, because then, and what you're thinking about is that's going to affect the primary outcome. Maybe you run out of pills in a day and a half, so you go back to the emergency department and you reprevent or something. So that's interesting oversight. Okay, so this is also just convincing you that year to year, you didn't have some huge change. Like nerve blocks were not in style in 2009, I guess, or I don't know what happened. Maybe they started paying for them or something. You have no idea. So you want to see that it's consistent, you don't have an effect over time. That's what figure 2 is showing. And then, all right, so this is where the study is. This is pretty much everything. You want to take us through it?
Sure. So the big and primary outcome showed a significant difference in the primary outcome, basically, with favoring those who received a nerve block. The p-value is less than 0.001. You know, we can't really say that it's highly significant given our defined pre-existing criteria, but pretty dramatic finding.
Yeah, it was a 1 in 10,000, right? To get a result equal to or more extreme. And that's sort of the formal definition of the p-value and the frequency study. So, so out of this, though, okay, so so they had 3,400 have one of these three things versus 2,800. So the idea is if you didn't have a block, potentially there's 600 more people who represented. Okay, and then the secondary analysis, they looked at sort of the longer term.
They looked at, instead of one week, they looked at 30 days and found similar trends.
Right, and then the other thing that people are interested in is what's the cost, right? So that was significant.
And then they found that the nerve block, the shock is associated with a slightly increased cost, like $350, I think was what they estimated out to be.
Right. Okay, sounds good. So there's a couple of nerve conduction studies, I guess. They had that on a few people with million data. Okay, so right now, just looking at sort of the primary outcome, nerve blocks are preventing this readmission. Right?
Or at least unplanned admissions, I think.
Unplanned. Okay, so what do we got in table 3? What was missing out of table 2? Okay, why are they coming back, right? That's what this is addressing. So what's the summary? Why do they come back?
Basically, predominantly for acute pain and then surgical site evaluation.
Okay, so presumably nerve blocks don't have anything to do with that. That's surgical dressing or suture. But pain. It seems like a low amount, actually, right? So you've got 30,000 people, you've got 700 representing. Shoulder surgery is fairly painful. It's sort of a low, pretty severe outcome.
Percent of people have this happen. Maybe it's a baseline number, right? Population basis is going to happen 1 out of 100 times due to surgery.
Right. Yeah, exactly. Or just everyone has different pain tolerance, different place they start with. So that's pretty interesting. So it seems like nerve blocks are helping, right? So discussion team. So what do we do with this information? Are you convinced this is a good study? Well, first, we'll go with, we should probably do strengths and limitations first. I have to go out of order. So what's good about this?
Large cohort size.
Comprehensive years, data set.
What about their analysis? Were they thorough? Yeah, I think so. And then the reviewers even had them do, they said like 600 different sensitivity. They made them redo it multiple times to make sure they got the same answer. With all that, that's sort of the idea behind that sensitivity analysis. They asked them to include all these different variables, which there's probably supplementary of what exactly that was. And once you adjusted for all those different things, the effect it sort of dilutes down your statistical significance. So after adjusting, it wasn't significant. With that said, though, I thought with 60,000, that seemed like it would be pretty well powered. You'd never do a clinical trial that size unless they might start to, but for the most part, it's incredibly expensive and very difficult to do. So I'd say the strengths and the size, the fact that it's a real world population. They didn't say you can't be in the study for all these different exclusion criteria, so it should accurately reflect sort of what's going on, what's actually happening. What are some other good parts of the study? So we got a good analysis, pretty thorough, large size. What about their endpoint? Do you think that's the most relevant endpoint? You don't look convinced.
I think it raises the question of what do we do with the pain, like long-term pain evaluation? Like, does this have a benefit long-term? I think if they're just literally trying to answer the question and pose an hypothesis, it's fine. And I think it was meant to be at least in part idea generating for the future.
Yeah. Yeah, I would agree with that. And I think, well, we'll get to the implications next, but what about limitations?
There are a couple we already mentioned, kind of, like which they help to try to like prove that limitation wrong or whatever, but using their different analysis to prove that getting where they got their data was.
All right, yeah, with the cohort.
Yeah.
It's billing data, right? So you're sort of stuck with what it is. You don't have a lot of control. You know, some of the strengths are also, from a different perspective, weaknesses, right? So it's population-based. You don't have control over who goes in there. You have a pretty extreme outcome, and they could come back for a suture problem that has nothing to do with their block, and they go into that same group of people. Now, if you flip it and look at the inverse, the opposite of this would be sort of a prospective randomized trial where you did very careful, like quantitative measures of pain, what's your opioid requirements, right? So really detailed information on fewer people, where you only let certain people into the trial and you randomize them and look at causation. Which, not to say that that isn't worth doing, because it probably is, but types of study are complementary because they give you different information. Because that tells you in a perfect scenario with this exact type of patient, here's what happens. So those are some of the limitations. So implications of that we're starting to talk about. First one I can think of is that we still don't know what the long-term implications of nerve block and nerve block. They didn't answer it, but they did show that we don't have all the information right now, probably because we're not collecting the right kind of data, right? So we don't know what happens in 30 days for a lot of these patients.
I don't really get the composite outcome why they decided to do that. Like as we're talking about, I feel like you see it a lot when you are having like a power issue with your outcomes, and so you have to group things together, which wasn't an issue here because we're not doing a power analysis. It's just like an epi study.
Yeah.
And so it just seems like say it was positive, right? Like say their primary outcome was positive. You would still need to do a sub-analysis to make the information useful, right? Like I would still want to know, okay, well, was it deaths driving it or was it unplanned ER? Like it's very different, process changes that you would need to make. Right. So it just doesn't, I just don't know why they sat on that as like the main thing. I feel like you want to just pick one of those as like your primary outcome.
Power it and go after that. I mean, the other way in epidemiology, if you have a rare event like this, they tell you to go case control.
Right.
Similar retrospective design, but then you can identify all the people who had a problem and try and match them to people who didn't as similar as possible. Limitations with that as well, right? Because it's convenient, but there's a lot of bias that can creep into it. So I think it does highlight the problem that the nerve blocks are only lasting between 12 and 16 hours, right? Maybe we're missing a window. Right, so some of the implications are that nerve blocks are great when they're there, right? So maybe it's day 3 that you need this. And I think they started to look at that with catheters, right? Maybe you could extend that.
They couldn't tell which was which. So, and then they didn't call them to find out how their pain was managed. So,
right, because maybe you're just stoic at
maybe
home.
you never got good pain control, maybe you never had it to start, and then you came back to the hospital, maybe your block failed.
Right. Yeah, exactly. That's just getting billed. You got charged for a block. Maybe it didn't work. So you can't really answer that with this. All right, so we're done with nerve blocks. We're going to cancel the acute pain service. There's an editorial too, where they go through a lot of the issues, which is kind of nice to frame it. Is that what this? Is that the implication of this research? Is that what we should do next? No, why not? It says it doesn't help that much. You can get readmitted.
They're supposedly helps short term.
Yeah.
So we do have that proof.
Right. So it's worthwhile. You can get it's a gold standard of pain control. Right? We've got a meta-analysis saying it's the ideal. So still worth it from that standpoint.
They didn't separate out people that are at higher risk. So your COPD patients or OSA patients that you don't want to send home early, so they're really better to do that. So if they sussed out the higher risk patients that would have benefited more from it, That might have given you a totally different answer.
Right. And then this last question is my favorite part. So, all right, so this is what we know now. What do you do next? What do we need? What would change practice, right? So this doesn't. Long-term? Yeah, we need long-term outcomes, right? We need to know sort of what's going on. I think we've got a pretty clear idea of what the problem is, right? We've got readmission cohort. Maybe there's risk factors for that. Maybe doing like a prospective cohort to see who is at risk. It's probably the usual suspect, which is substance abuse, depression, anxiety, previous chronic pain, neuropathic pain, some of these other things, CRPS, but maybe targeting patients. Maybe you don't need to go after all 60,000. Most people sail through it. It's fine. Maybe you go after the high-risk ones and then target interventions. That's another way to reduce readmissions. If you know who it's going to be, you have a higher clinical suspicion for that, maybe that's who you target. Maybe they get catheters, or maybe they just stay in-house, don't stay home, right? So there's other, we don't know what those interventions would do or what else.
I think that would have been a better like utility for this paper is like to set up something down the road where it feels like they were just trying to, I don't really know.
They probably are, but they're not going to tell you all their ideas. Like you still can't, right? They'll set it up.
But it wasn't set up to identify like where your intervention should take place, in the future. So
no, that's true. But I think they characterize the problem pretty well. Probably the next study I would do is that one. Try and take high-risk patients and say, and probably a trial, right? Because you can get a lot of information about causation, which is very difficult with any other study design. And that's usually what will change practice, is if you can show that you took identical people and prospectively randomized and you saw a big effect, which you might if you could find an intervention that would sort of better control acute pain. All right, so let's go back to our learning objectives and make sure we hit all of those and see if there's anything else you want to know about a retrospective study, any questions you have about that or thoughts on just this study or other studies in general that might come up, if that makes sense. Seems good. All right, thanks very much.
Thank you.
Thank you.